allowances that we fought for was instituted and later incorporated into the salary. It stemmed the tide quite a bit. In fact, before, let me just give you some numbers. Before we did those demonstrations and things like that for the government to improve the conditions, in a typical class of the University of Ghana Medical School, those times the numbers were small, maybe about 60 to 70 per class. After about 5 to 7 years, only about 10 will be left in the country. Now, after those conditions changed in the early 2000s, even my own class, I can say almost half of us are still in the country. Oh, wow. Which was and then the subsequent classes, a lot of people stayed in the country. But the 20 years has come, and things have plateaued, and now the young ones are living in droves. And so we are training them, but they are living. So the question is, this issue that, my friend talked about the, no clearance to employ the people that we've trained. I found it very fascinating and very interesting because it takes a lot of money to train these health workers.
Okay.
In the US, a doctor, by the time they finish medical school, right, they will be owing about $200,000. Think about it.
$200,000?
Yes, to train one doctor.
Okay.
Now, we would train the same doctor here in Ghana for virtually nothing. And then we say we don't have clearance to hire them. It doesn't make any sense. So then that person leaves and goes and works for somebody who has not spent any money training them. Okay, so for me, I don't buy it that we don't have money to hire nurses or doctors, because we have the money to train them and we don't have money to let them stay and work. You get what I mean? So I think it's all a matter of priorities, I would say. But the problem is huge. Now, the doctor numbers again has improved, but the number of specialists in various fields, right, is very abysmal. The whole country of 30 million, we probably don't have more than 30 cardiologists. Okay.
These numbers that you're mentioning, Prof, these are numbers that you are saying that in spite of the fact that it doesn't look that bad, it's only between Accra and Kumasi and Mitadi to an extent.
Oh, yes. But that is the general pool of doctors. Okay. You see, it's like, my friend was saying, sometimes when we talk about these things, we lump everything together. We say, oh, nurses, oh, doctors. But medicine is a very complex field, and you have a lot of specialization. Nursing has a lot of specialization. Medicine has a lot of specialization. So if you have a kidney problem, you need a nephrologist. Oh. The number of kidney doctors in this country is not even up to 20. For 32 million people, I mean, that is like unheard of, right? If you look at cardiology, rheumatology, even infectious disease specialists, very few. Okay, so
these are leaving.
Yes, and people who can, train to become all of these are leaving. Okay, so we need to really do something about this, because otherwise we're going to lose a whole generation of doctors.
Okay, so listeners, it is Z Roundtable. That's a Friday conversation we do right here in these studios. And you just heard Professor George Boateng. He's a consultant physician from the Noguchi Memorial Institute for Medical Research. And also we have Dr. David Tenkran-Chum. He's a lecturer at University of Ghana and also the General Secretary of the Ghana Registered Nurses and Midwives Association. We're having a conversation around what we are calling the medical brain drain and also the blame games, desperate shortage of health workers. I was wondering if the word desperate we used was too strong a word, whether it was too acute, but hearing from Prof and from Doc, it looks like it is a correct word to have chosen. That is a desperate situation, but I don't know whether we see it as it is. So now let's tackle these things one by one. Let's first go to causes and factors. Let's look at the primary reasons why Ghanaian medical professionals are leaving the country. Is it the money? Prof.
It's a good question. Of course, the money plays a big role in this. So when you talk about the push factors, one of it is the remuneration for healthcare professionals. So our remuneration for healthcare professionals is very low compared to, of course, other places in the world where our professionals go. Our professionals usually go to a few places, actually, the UK and the US.
Oh, okay.
And then maybe South Africa, a little bit in Australia and so on. But these are the two main places that, they go to. And they go, yes, the money is definitely a huge part of it. The other thing is opportunities for advancement. Where somebody wants to train in a particular area that they think the opportunities here are not enough. That, like I said, when the Ghana College of Physicians and Surgeons was formed, at least for the doctors, it has improved. And I think it has also improved for the nurses as well. So now I would say one of the biggest issues is the remuneration. And when I'm very passionate about this because as a young doctor, I was one of the leaders of the fight to improve. So I know kind of how these things are. You finish medical school, you do your house job for 2 years. After that, you're a medical officer. That is usually where the problem is, okay? That is usually because from medical school all the way till you finish housemanship, it's like automatic, okay? But once you become a medical officer, then the question is, I think that is when we should aggressively work with them and give them conditions that will make them stay. Because if I'm a young medical officer and you send me to Bolgatanga with accommodation and everything set up, and I know that when I go there I can't. Even if you post me there for 2 years, I may have a child or two. The appetite to uproot and leave goes down. You see,
family ties.
Yes, the appetite goes down. But if I'm single, I'm in Accra, I'm roaming around, there's no clearance, those things, then I'm like, okay, I'm just doing locums around. Okay, why not write the US exams? Now, know that so that is the push factors, right? But the barrier, so when you are going, it's not that easy. It's not that easy to go and practice medicine in the US. You have to take 3 or 4 exams. These exams are expensive and they are hard, okay? But our medical students are smart. They can learn and they can, but it's still not easy. It's a barrier, okay? So it's not like people just wake up and go, when they feel like they have something for them here, right? The barriers, there are barriers over there too, but they try to overcome all of these barriers to go because the pull factors within the country are not enough, So we have to, work to make sure that, things that young professionals need to survive and stay and work are available. And we can talk about some of this later.
Okay. So, Prof, you place this in a very fantastic light in my understanding. So there is a push factor that is pushing them out. There is the need for a pull factor that will pull them back in or cause them to stay.
Correct.
And there is a barrier where they are going. Are there pull factors also from where they are going to that is drawing them, aside the fact that maybe better working conditions? Is there something else we've not thought of which probably could also be driving them there?
They may get better, opportunities for themselves, better training opportunities. People look at better conditions for their children, and so on and so forth. So there are a lot of factors, but those things I don't think are major, because I always say, if schools in Ghana are as good as anywhere else, in terms of, when these professionals will be able to get their children into all the good schools in Ghana. So those are not the big ones. But so the big ones are what we're talking about. Mainly financial, and secondly, training opportunities.
Okay, let me come to Dr. David Tenkrachum. Doc, I can understand the doctor who is done with his housemanship and is lingering around. Maybe he's needed here some few hours here, he's not really stable. What is the situation with the nurses? Right. What do they do? So those that are now, the 2021s that we're employing now, what they, then the 2021, 2022, and the last year's zone, what do they do?
Okay, so that's a good question. And that is where sometimes I want our health managers to direct their attention to. Let me give you a practical example. A month ago, I went to Kufrudia Market to go and buy something for my family. And it was a Sunday. And I saw a nurse frying, what do they call it? Donut. Let me put it that way.
A nurse?
A nurse. Somebody who has completed.
You knew her as a nurse?
And has not been employed. Yes, somebody I taught at University of Ghana.
Oh, you taught one of your students?
A graduate nurse. You see, in Ghana, I have various levels of entry. Unlike the doctors, everybody is a graduate. We have 3 levels of entry. What I'm talking to you about is a graduate nurse, somebody who has completed University of Ghana, has finished national service, 2020 batch, and was at home. And I saw her and I was devastated. So that effort, all the effort that we put in was being wasted. Okay, so they tend to find themselves in menial jobs. Those in the cities are able to get locums to do. Prof mentioned about locums. But because of our numbers, you see, they don't get those opportunities. In places like the regional capitals, the district capital, which hospitals are you going to do locum there? Most of them are clinics, some of which could pass as abortion clinics. So, I mean, what kind of locum are you going to do over there? So, they are really suffering. And even if they get employment opportunities, the compensation is nothing to write home about. Okay? They take them for cheap, of course. I mean,
yeah, because I mean, it's a demand and supply.
Demand and supply issue. So if quite a number of people are around, they are not getting any employment, and you come and even bargain anything higher, they will step you aside and pick somebody else. But Prof said something significant about the pull and the push factors. Mm-hmm. Now, it's indeed true that you don't just get up and go and practice. You have to write certain examinations. For instance, for the nurses who want to migrate to Canada and US and Australia, they have to sit for NCLEX. NCLEX examination is difficult. Okay, as a lecturer, I don't want to give myself away, but you pick certain questions from various areas, and the NCLEX questions are structured in such a way that you can have same answers or same options, but you are looking for the closest.
The best answer.
The best answer out of similar answers. And it's very difficult to pass those exams, but they still write the exams and they pass. Some travel as far as India to sit for the exams. South Africa, in fact, the whole of Africa is only South Africa that has a center to write NCLEX exams. Can you imagine plane ticket, the risk?
These are people who are determined.
Exactly. So that should tell you that we are having major issues. Okay, so the primary reason, Prof, I don't want to belabor the point, is the compensation. Compensation in terms of salary is terrible in Ghana for nurses and midwives and other healthcare professionals. Look, let somebody, so the exodus is not like people traveling outside Ghana. There's also attrition even within. If I'm a nurse at Bank Hospital, my compensation is different. So I might be paid double the salary that I receive at Bank Hospital vis-a-vis in Ghana Health Service. So even within, there's attrition. But what is more troubling is those who are going
those living the shores.
So the compensation is bad. And a prof said something that, I mean, the early 2000s, there was let's fight for additional DT hours allowance, which got consolidated onto the single spine salary structure. The ADHA also collected some.
Yeah.
And see what happened. At some point, it was captured as market premium. That additional DT hours allowance was captured as market premium on the single spine salary structure. In 2013, it was frozen. It wasn't removed, but it was frozen. Previously, any time that the salary inches up, the market premium also inched up a little to sort of compensate for the inflation and the rest of it. But since it was frozen, anytime salary went up, that stood still. And that has shrunk. So initially, I think nurses were started with 0.58%, let's say 58% of their basic salary. Okay, up to a point. So from the least nurse up to senior nursing officer, 58% of their basic salary was market premium. And from principal nursing officer, DDNS was 75%. And the above was, I think, 100%, the specialist. As I speak with you, if I should compute a nurse's market premium, which stood at, let's say, 58% of his or her basic salary, it will be less than 20%. So all the gains...
So things are becoming bad.
Terribly bad, not just bad. And I'm saying that all the gains that we made, as Prof alluded to, on the single spine, had been whittled away by virtue of this phenomenon I've mentioned to you. So the purchasing power of the ordinary nurse or midwife or doctor is completely down. And that's why they are leaving. And they don't see a future.
Yeah.
That is always a worrying one. Thank you so much for touching on that. I'm informed that Dr. Kwame Sidu Sapon, the CDD Fellow on Health, has joined us. Doc, good morning for joining us. Thank you so much. We're talking brain drain in the medical field. Could you share your thoughts on it broadly before we go into the specifics?
Well, thank you and good morning. I hope you can hear me.
Yes, we can hear you.
Yeah, I've been listening, and good morning to my colleague panelists. And those in the studio have been sharing broadly the main drivers of the brain drain. And so I wouldn't want to add on to it to belabor the point, because the drivers, you see, in every decision to migrate, there's the push and there's the pull factor. And the decision, human beings by nature would always go, irrespective of what profession they are in, by the Maslow hierarchy of needs. The bottom of which is food, clothes, and shelter. The next level, absence of fear. Then you go to social needs, then you go to esteem needs, and you go to self-actualization. Every human being going through their professional journey, be it a doctor, pharmacist, nurse, when they graduate, the first thing they want to do is to find something to eat, something to wear, and where to stay. Then, obviously, irrespective of the route you take, you do some form of pupillage, be it house officer, be it, a year understudy, whichever way you take. So let's just use the generic name of house job. You do a year's house job. At that time, you are learning under experienced professional colleagues. And so there is that level of, oh, I'm learning, what can I learn? If you have the safety net of those professional colleagues who are experienced, because you have to bear in mind that health is not just a science, it's also a skill, it's a vocation. And you pick the tools of your vocation as you go along, and often you pick it from your more experienced colleagues and members of the team. You pick from nurses, you pick from pharmacists, when it comes to pharmacists, you pick from doctors. That is how it helps. So as you go up the pyramid, then the absence of fear comes in. So you are not scared of taking on certain situations in the workplace, because obviously you've picked up the vocational skills to allow you to, perform. And that's at that absence of fear level also comes in with your professional training. So you either go and do a specialization or go to the Ghana College for physicians and surgeons, or for pharmacists, or nurses, and all. And then you're going on. Then you get to the point where you get to your social needs. Maybe you become, a consultant, a specialist, a fellow of the college. And then you get to your esteem needs, where then you start returning your expertise to the society, to the point where you get to the levels of the professors and professor emeritus, where you've achieved everything, and it's self-actualization. How can I improve on the lot of society? So you have to look at the health professionals' journey along these lines. At every point, they have to take a decision based on push-pull. So for example, if you are at the absence of fear level, where you need to get training and all that, or you need to pick up the skills and tools of your vocation, and your very experienced consultants are leaving, you would worry. because you ask yourself, where in my opportunity to get the competence I need to practice? And one thing you have to bear in mind is that, unfortunately, with health, and I'm quite sure my colleagues in the studio would say, as you pick your vocation and your vocational skills, there is a direct correlation with mortality. If you don't pick it well, people die. In the profession we practice, if you don't pick it well, if you're a doctor, you don't operate properly, people die. You misdiagnose, people probably will die. If you're a pharmacist, you give the wrong medication, people could die. If you're a nurse, you give the wrong injection, people could die. So as you pick your vocational skills, you are tarring it against the lives of the citizens, because, for want of the word, those citizens are your guinea pig of practice to pick your vocational skills. So that is why the absence of fear part is very important in every health professional vocation. So when you are at that level as well, you are very vulnerable. So if the pull factors exceed the pull, and the push factors exceed the pull factors, your chances of migration is very high. As you go up the ladder and you get to social needs, you've got a family, you probably are a specialist and all that, traditionally, migration was tailored down. Unfortunately, as a result of our currency and depreciation of the cedi and all that, formerly, as you moved along, in dollar terms, your earnings were increasing. Now I speak to my colleagues and they'll tell you, in dollar terms, some of them are not even earning. Yes, in cedi terms, they probably are earning a lot of cedis. But in dollar terms, due to the exchange rate, their purchasing power parity is not the same as when they were at and that for me is a policy conversation that those we put in authority to take policy decisions are not avering their minds to. And that for me is the challenge.
Asiru Sapon, he's a CDD for Democratic Development Ghana. He's sharing his thoughts on this very big issue. We're looking at the causes and the factors. Now let's move on to impact. Let's move on to impact before we come to the rest. And I will put myself into this story because I recall, I think, the birth of my son when when I was around there, I was called from the bank. I had to rush there, and the woman was not doing too well. And up to today, she still tells me, if that senior doctor had not come, she's totally convinced she was dead. And she still tells me the story because I wasn't in there. So this is my wife telling me over and over again that, oh, when the man came, he said he should do this, and that's what stemmed her bleeding. Otherwise, oh, she was dead and all that. Now, from what Dr. Sapon just said, it's telling me that those people as well are also leaving. This then makes it a desperate situation. In your experience, Dr. David, what has been the impact? How does this medical brain drain we're talking about, how is it affecting healthcare delivery in Ghana?
All right, thank you. That's a good question. You know, as I alluded to earlier on, I made mention of qualitative exodus.
Qualitative, yes.
You see, you have well-trained nurses and midwives, doctors, physicians living. So, like the story you shared, if that specialist who has been around, who know his way or her way around, had not turned up at that material moment. So the impact is about patient safety and quality of care and health outcomes. Okay, so some mortality could be averted, but by virtue of the fact that we don't have certain specialists, the people will go. Okay, so not long ago, I was talking about the entry point of nurses and midwives, and some people took me on. Perhaps they didn't appreciate what I was coming from, to the extent that they felt that, I mean, when you go to other jurisdictions, you have LPNs, you know, other lower cadre nurses and midwives and stuff like that. But look, evidence abounds, profited, that highly skilled healthcare professional is able to reduce the odd ratio of mortality. And there are several, I mean, 2014, there was a research that was conducted and published in Lancet, where just increasing the baccalaureate entrance of nursing and midwifery was able to avert mortality by 7%. And many other researches that were done in almost 300 countries. You see, so where they start off, one on the single spine is a terrible thing, and as I said, once the experienced ones are leaving, it will certainly impact on patients. And that is where I come in, because I had 80 years of clinical practice before moving into academia, and I saw a lot of things. So I speak, or I come to this position with a lot of knowledge and experience. Patient safety, health outcomes are extremely impacted when you have well-qualified nurses and midwives, experienced surgeons living the shores of Ghana. And when somebody starts crying, oh, I went to hospital and the kind of services I received, we have created it ourselves as a people, because we have not prioritized health workers. We think that they are nothing. You see, we only need them when we get to the lowest ebb of life, which is when we are sick. People see Prof drive around, do you understand what I'm saying? They only get to experience them or get to see the importance of these people when they are at their lowest ebb of life. That is when you are sick. So we need to prioritize the remuneration so that we can improve upon these adverse impacts that we are having. But I'll come to certain non-financial, maybe we'll go there. We'll talk about some of the monetary and non-monetary incentives that will certainly serve as a bigger pool. You understand? Exactly.
I'm sure eventually
we will get there.
Prof, are there special areas, specialties that are leaving or are most affected by this brain drain?
So, like Dr. Stede said, previously it used to be mainly medical officers, you know, people who have finished a house job and, you know, they stay in the country a year or two and then they leave. But now the guys in the, you know, UK and Canada and the rest have opened up their system such that our specialists here can also leave. Now, the issue of medicine is that in a lot of countries, like in the US, if you finish your specialization here and you go to the US, you still have to take the boards or the medical exams, and a lot of specialists are not interested in doing that. You get it? So that was like a factor that kept people in here. But now, if some of them have begun to open up the system, such that, oh, if you are a specialist in Ghana, oh, you can come, we will just, you can almost immediately start practicing. So that is really dangerous for us. So for me, that is a huge problem that we have to make sure that, we do everything to keep our specialists safe, because it's not like we have enough. Okay, we don't have enough. And your question about what is the impact? If you go to a hospital right now, the number of specialists are very, very few. They are nowhere to be found. You can build hospitals. You see,
Agenda 111.
I don't want to get into politics, but you can build hospitals. But who is going to work there? Okay, if you build a hospital, you don't have doctors, it's just a building. You don't have nurses, it's useless, right? So we need to prioritize the workers first. If the workers are staying, it's excess of them, we can expand and put them where they are supposed to be. Or we can do the two concurrently. Okay, but we need to really prioritize the doctors and the nurses and the pharmacists and so on, because if we don't do that, then our healthcare system will begin to slide back down. Okay, to begin to slide down, because when you go to a hospital, it's not a building. It's the people who are working in there. It's the nurse who will give you the right medication at the right time. Let me give you an example. At UGMC, it's a new hospital. We are doing great things there. But the ICU is the biggest ICU in the country.
Okay.
You can't get ICU nurses. They've all gone to the UK. They train in Kolebu. My friend and people train them, but they've all left.
Oh.
Yeah. and when it comes to ICUs, you need ICU intensive care when you are most sick. Maybe you need to be intubated for a little bit, to get your lungs ready.
First port of call.
And they have gone. They are gone. The experienced ones, they've left. Okay, so, and when it comes to, inpatient care, the nurse is like the most important person, because they are with the patient all day. Doctors, we make rounds, we, write orders, and we go and see somebody else. But the nurse is the person all the time. If the nurse lacks experience, you're in big trouble. Okay, so we really need to think, and I like what Dr. Sidi said, we need to really have a conversation on this, because if we just do business as usual, by the time we open our eyes, our specialists are gone, our young ones are gone, our nurses are gone, and what will we be left with? Some of us came back to this country, you were asking me, because for me, I always say that, well, it's our country. If you don't build it, who will build it for us? But we need help. People, we all have to come together to make sure that, things are done that will lift, our healthcare system. Because the thing is, what I always say is that, look, I'm very passionate about training the young ones, because, look, tomorrow, you'll be in the emergency room, and it's that young doctor who is going to take care of you. Okay? Whether you're a politician, or you are what, or you are famous, celebrity, or whatever, if you are in trouble, where are you going to end up? You end up in that hospital. If you don't make that hospital in, Fanchiniko very well, you are traveling, you get in an accident, that's where they're going to send you. If you go there and there's no doctor, are you going to survive?
No.
You won't survive, so we need to think in those kinds of terms and make sure that the conditions are good. The other push factor is the working conditions, the hospitals, the availability of staff, of things for the professionals to work with. As professionals, we learn these things in school, okay? You learn it in school, but then when you go to the world, it's not there. You got what I mean? So the environment of the work is also very important. You know, you need to make sure that the facilities are available for the nurses to use, for the doctors to use. There should be a nice environment where the work is very stressful. You know, it's very stressful. So we have to do everything we can, you know, to make sure that people are staying.
Do you, Dr. Tunkrantumi, let me find out from you. You training them, you know how good some are, the very best that you've trained. Do you know personal experiences of them, if they are here or they are planning to go or they've left? Can you share some of these experiences with us?
Thank you. I spoke with one yesterday.
Oh, is he here or is about to go?
She's there already. She's in US. And she left in January. She tells me almost every day she picks people from the airport in the United States.
Oh, wow.
Yes.
Ghanaians coming.
Yes.
Yeah.
Nurses coming. So she went just this December. She has been able, so she has become she orients people over there.
Oh yeah.
Yeah, the agency that sent her, she knew how to drive very well. So when she was going, she spoke with me. I said, why don't you pick international license? So she went in there and, you know, applied for US license. And now she's driving. And the agency has made her like the who picks people. And I was devastated when she mentioned that to me. It means that the people are living in droves. Prof talked about the conditions. Of course, we can talk about medical logistics, lack of them, and the rest of it. But let me give you a practical example. Do you know that nurses and midwives in Ghana, and in most facilities, when they fall sick, they have to dip their hands in their pockets before they can be taken care of?
Wait.
Oh, you have no idea.
They're the nurses themselves.
Not only nurses, all health
workers.
It's only few hospitals, like maybe UGMC, few hospitals.
Yeah.
They have put in certain policies that once you work here, when you fall sick, we take care of you. But I'm telling you that most of the nurses, but of course, if you are a nurse and you are working in a health center or a chip center, and you get appendicitis, obviously that facility cannot take care of you. You have to move to maybe a district hospital or a regional hospital by virtue of the fact that whether you even work there or not, I'm telling you, even when you are on health insurance, some of the drugs are not covered by health insurance, and you have to put your hand in your pocket.
The salary that is not.
Lab investigations, you must cough out money.
That's a reality.
That's a reality. We work in the health sector, and we don't have any form of insurance. And let me tell you something. You see, you pay almost 27 Ghana cedis as a citizen to renew your national health insurance a year per annum. Let me tell you what the health workers pay. You know, 2.5% of our 18.5 retirement deduction goes into national health insurance. That 2.5% of my basic salary, let's average it to be 50 Ghana cedis a month. If you annualize it, it's 600 Ghana cedis. So that poor nurse, that poor doctor, pays 600 Ghana cedis and more towards national health insurance. Yet he or she, and as part of working in such a precarious, infection-laden environment, like a hospital, will receive the same services like the gentleman who sits at Abossey Okai and pays 27 Ghana cedis a year. So it kills me. Look, there are several organizations that when you fall sick, I mean, they're able to take care of you, and even your spouses and your children, about 4 children.
Yeah.
We have that stated in our condition of service, but it's not implementable. I'm saying that the nurse, the midwife, the doctor in that particular facility, every facility that he works with, will have to pay money when he falls sick. And that is how bad it is. Okay? Meanwhile, you have somebody, a journalist, I'm not picking on you, but will come, and that person will be taken care of by this establishment. Why can't same be extended to us? I don't get it. And at some point, Ghana Health Service wanted to break a policy, which Ghana Medical Association and Ghana Research Nurses Association kicked against it. They were going to take 2%, apart from we paying 2.5% of our 18.5 retirement deductions to national health insurance. They're going to take 2% of our basic salary. Okay, again, as insurance, to form an insurance for us, so that in case you fall sick, you know, and the disease falls outside the remit of health insurance or whatever, you can be taken care of. I should insure myself to work for you Who does that? I should pay money from my meager salary to ensure myself to work for Ghana Health Service. It makes no sense. You see, so these are some of the things. Look, we negotiated for rural incentive, okay, for nurses and midwives, and even doctors were part. Can you imagine that as I speak with you, it's gathering dust on shelves? It has never seen implementation. And we did that negotiation in 2020. So, I mean, what is the motivation for me to go to any rural setting? And there are other non-monetary incentives. If you are working in a deprived area, you are supposed to be promoted, not out of 10, but like you have a shorter promotional line. So if I'm working in Accra, Kolebu, and my first promotion comes in the third year, you should be promoted after 2 years. Similarly, if I'm supposed to be promoted every 5 years thereafter, you have to have yours reduced by 1 year, meaning that, okay, but it doesn't happen. When it comes to study leave, let me tell you, see, and that is why some of us were calling for the entry point of nurses and midwives to start at the degree level. Because you see, when somebody starts at a degree level and comes up, one, he starts off a little better on the single spine structure. And then the agency to even move on to do masters and PhD is not there immediately, it's delayed. Because at least the person has a first degree. And some of them settle in marriages like what Prof is saying, and therefore the agency, the urge to move on to do unless those who want to go into academia or something, okay, who want to do a master's and a PhD immediately. And I have colleagues that I come to the University of Ghana with that they are still practicing with their first degree. Some have settled in very well with their spouses. Okay, and those ones who are posted to the villages, diplomates, certificates, and stuff like that, they don't get study leave to upgrade themselves. And let me tell you something, if you train somebody at the certificate level or diploma level, it's even a cost to the state, because in the next few minutes, the person wants to go and do the degree. And you have to give the person a study leave, which they don't get anyway. But I'm trying to say that if we are to follow through the process, they should be entitled to study leave after having served about 3 years. You get my point? Or 5 years. The study leave doesn't come at all. These young people are virtually left in the villages, and it's a cause for worry. You will not meet me and I'll smile at you when I'm in such a precarious environment.
I understand perfectly what Doc is saying. It's 9 a.m. It's still Z Roundtable. It's Z in the morning. We just 9 a.m. means we've 55 minutes approximately to wrap up. Dr. Kwame Sidu-Sapon is with us. He's via Zoom. He's a CDD fellow on health. Dr. Sapon, if you are there, listening to your colleagues, what can you share on this very part of the conversation that we're having, the impact? Can you give us personal experiences or stories of how this brain drain has affected healthcare from where you sit?
You see, it's interesting listening to my colleagues speaking. And the sad thing is, not a lot has changed from when we graduated in the 90s and all that. And that's worrying. The same issues that were being highlighted that led to people leaving are the same issues that are being highlighted today. And you see, it is like me, who works in the policy space. I know my colleagues would always say, oh, I just heard, oh, I don't want to go into politics. But these are matters that are known to the policymakers. There are a lot of documents that are published with taxpayers' money on our health system. I can give you a few. The holistic assessment of the health program of works by the Ministry of Health. There's the Ghana Statistical Service publishes the Ghana Demographic Health Survey. And there is also an assessment that is published by the Ghana Health Service, the Ministry of Health, and the Global Fund and WHO on our health systems, called the Health Harmonization Report, which tells us what is actually needed in our health systems. And if you look at the Health Harmonization Report, the last one was published in July, it tells you that only 5% of our consultation rooms in public hospitals have the full complement of equipment to come out with an adequate diagnosis, which means 95% don't have. And I'm quite sure all of us have seen these reports. I ask myself the question, when these reports come out, one, do the journalists even pick up these reports? Because you see, getting these issues sorted is not just the remit of health professional practitioners like my colleagues and myself. It is also a citizen's responsibility, because at the end of the day, like I said, health is a vocation. And like you've heard my colleagues say, if you went in there and you didn't have the professional with the right vocation, and you've alluded to it when your wife was giving birth, you could lose your life. So the citizens have a real role to play in ensuring that these corrections are made. So when reports like that come out, and it's not the main discussion on our regular news networks, so that health is prioritized. When we have government, which as far back as 2001, go and sign the Abuja Declaration, which says 15% of all government spending should be invested in health. And since we signed the Abuja Declaration, we haven't even done more than 6% under any government in the last 23 years. And you have the Kampala Declaration that was also signed by another government in 2008, which looks at health worker migration, and we've done nothing to implement it. And then we have all these reports coming out, which talks about our poor outpatient per capita, which talks about our lack of equipment, which talks about the fact that our health systems, doctors, nurses, pharmacists, laboratory technicians are practicing in infection-laden facilities, and nothing is done about it. And no one is having the conversation. But when all these things are known to the policymakers, and the policymakers know our doctor-to-patient ratio, because that is found in the holistic assessment of health. They know the pharmacist-to-population ratio. They know the nurse-to-population ratio. They know that 6 teaching hospitals in Ghana, because their training facilities take up to 2/3 of all the doctors that currently are on the Ghana Medical and Dental Council roll, because they are training facilities. So people are affiliated there and all. And they know we do not have the health human resource, because health is an
read it the way it came. I think it sounds better that way. I don't want to paraphrase. To whom much is given, much is expected. So for all that goes into training the doctor and the nurses, doesn't patriotism expect us to give so much to Mother Ghana? Let's start from I like the who. It means that this one is a question that has stoked something. Let's start with the General Secretary of the Ghana Registered Nurses and Midwives Association, Dr. David Tenkranchu. Patriotism.
Okay, that's a brilliant question. Yes, I mean, but he premises on a very wrong note. Who says that people don't pay for their tuition? You know, gone are the days where, I mean, virtually tuition was free in Ghana. Go to the medical school, come to School of Nursing, where I lecture. Almost 60% of the students are fee-paying students. Okay, so we are not training people for free as we used to. Maybe some it's been there, we talk about it, but people don't really know the nuances of what goes into the training. People are paying for their training. Now, previously, when I went to nursing training, we were bonded. So virtually everything was free, we were given allowances and all that. Move to private universities, people are paying fees. Go to medical school, University of Ghana Medical School, we have fee paying, especially those who are doing GEMP and the rest of it. Even those who are starting from SHS, there are people who pay complete fees. So this old adage of whom much is given, much is expected, of course, is in the Bible, but that is not what has been experienced in terms of the current training of our nurses and midwives and the rest of the health workers. Okay, so that's why Prof is here, that's why I'm also here. So patriotism, yes, we are here, but patriotism doesn't take us to the market. And we expect the public to even speak for nurses and midwives and health workers, like what Dr. Sapon was saying. You see, we sit back, and when we need them, that's when we get to realize, oh, they are important. But let's prioritize health. Okay, let's prioritize health, because you see, the health of the people is the wealth of the people. And therefore, when we begin to belittle some of these things, it's a cause for worry. Okay, the young lady I was talking to you about, she's my niece. Okay, I took her to school. She went to Western University, and I actually had to support her and all that. I did some adjunct lectureship at Western before moving to University of Ghana, because I needed to gain some academic experience, because I was basically at the clinical area. And yesterday she told me that 1 week's salary, her 1 week's salary is 7,000 Ghana cedis. How much do I receive as a lecturer in Ghana? I hope you understand. So yes, quite a number of us are patriotic, but they should help us. You understand? In this conversation, they shouldn't just make it look as if we have been taken care of free of charge. And who says, I've never received any scholarship throughout my life. Secondary school, of course, I got a bursary scholarship, but even that, I also had cocoa scholarship, because my father was a cocoa farmer. And I dropped the bursary because my headmaster called me and said, why don't you drop one so that somebody benefit? And the other person couldn't have gotten the cocoa scholarship. So I said, let me drop the bursary and let me pick up the cocoa scholarship. Of course, by virtue of the fact that my father was a cocoa farmer, producing a lot of cocoa. Now, since then, I have never benefited from any scholarship scheme. Even my PhD, I funded it myself. So, we are here and we are serving, and we continue to serve, we continue to impact knowledge to the young ones. And when you have a dedicated person like Prof sitting in your studios, and somebody will also question his what do you call patriotism, patriotic instincts, then that's not right. But yes, he's right to a large extent, but I just want him to appreciate the nuances of training. Now, quite a number of students foot for their fees. They are paying full fee for whatever training that they are getting. So we are so patriotic. We continue to take good care of our people.
Prof, I cannot leave the patriotic without, because first of all, what took you away? What brought you back? I want to hear from you, because I'm interested.
Yeah, so I finished medical school at University of Ghana Medical School, and then I was very passionate about this topic we are talking about, you know. So I was the leader of the junior doctors then. Tell you a story. So we were doing a lot of agitation at the time, and we had a lot of radio interviews. The late Nyama Donko was the Minister of Health then, you know, God bless his soul. Very fine man. And I went to the castle then to see Professor Mills. He was the vice president then. And he knew me from somewhere else, you know, apart from, yeah. So when he saw me, he said, George, I don't know how I gained them. So I said, Prof, look at this situation. Now we're agitating and all of that, and it's uncomfortable. But look at this situation. You go to a district hospital, 200,000 people. There is 0 doctor. A woman gets, you know, in labor, they have trouble. They need to travel on bad road to the regional hospital. A lot of these people die. Now, if you made the conditions better, and some of these doctors stay, that district hospital has a doctor. Can you imagine how many lives will be saved? The professor looked at me and said, hey, my point. You know, so after that, that's when, you know, they brought additional allowance. But then they shouldn't have frozen it. They should have kept it up with inflation. You see, because if you don't keep it up with inflation, it becomes worthless because of the depreciation, you know, of the cedi. You know, so that, for me, I left because I wanted to, after medical, I like research, and I wanted to get a PhD in, you know, in molecular microbiology. So I got a PhD in molecular microbiology. I trained in internal medicine and also specialize in infectious diseases. So I do both research and also see patients. So
Okay.
And
what brought you back? I'm interested in that bit.
It's Ghana that brought me back. Honestly, when we were leaving, my wife and I said, we spent 10 years and come back. We spent 13, but for me, I always say that it's our country, who is going to build it for us, right? But talking about patriotism, I mean, you can't go to Makola and say that I'm here to get tomatoes, because I'm a doctor. Right? I mean, it doesn't work that way. You need to take care of the people. Although our fees here may be lower than, say, what is, elsewhere, in our economies, the fees are so high, right? And even if, doctors are not the only people who, if you like, pay low fees. I mean, how about engineers? So why do you always, talk about doctors being the patriotic ones, right?
Because you went into a field where you have to save life.
Yes, but we also need to eat. If you don't eat,
you must genuinely, inherently, you must be patriotic to be a medical professional.
Yes, but we love our patients, okay? And doctors in Ghana sacrifice a lot. Okay, they sacrifice a lot. They work very long hours. Same with nurses. We work very long hours and for very little pay, right? And when we were, agitating those days, what I used to tell myself, look, my father was a customs officer. He was able to take me to Ghana National College. Those times you have to pay fees, boarding fees, and all of that. And when I look at my salary then, I couldn't take my child to the same school. I mean, how? Yes, as a doctor, I mean, that is ridiculous. So if people look at their conditions like that, they are going to leave. They are going to do whatever, they can to live, right? So we need to, make the conditions such that people will stay.
Okay, thank you so much, Prof. But I still need to touch on the patriotism question with Dr. Kwame Yusuf. No, I want to come to you quickly. This one is just by the way. Dr. Sapo, if you can hear me, patriotism. Our taxpayers' money help. Although you might be paying some money in your training, but our taxpayers' money help to a great deal to train you. Why are they leaving? Why are they not being patriotic by staying? Is my thought in the right direction if I ask that question, Doc?
Okay, thanks. You see, I have the benefit of history, rather fortunately or unfortunately, because my dad was a professor as well. Trained abroad in Canada, in fact, in Israel, the United Kingdom, but in Canada. So my siblings were all born all over the place. And when he finished at the UBC, University of British Columbia, where he was a lecturer and a reader, he decided to come to Ghana at a point in the 70s with all of us because of the word patriotism. He felt he had to come and give back to his country. And my dad was a forester. I'm quite sure all of you that crack Kumasi Road, so you would know that Dadieso Railway crossing. There used to be a large teak plantation on the right-hand side. That was the first teak plantation my dad did when we came to Ghana. Because at that time, he was introducing teak into Ghana. But at the same time, when you go to UBC, the portion that he introduced the teak and pines to do his PhD is still there today. That allotment was planted in 1962 and is still there today. As we speak now, in 2024, the allotment he planted in Ghana in the 70s has all been raised down and it's being used for a church. That's why I've shown you the exact spot. You drive past it, you will always see it. It's being used for crusade or something like that. It's been raised actually today. Secondly, after all the years, having become the director of forestry research, Ghana, and chairman of the Forestry Commission and all that, and Daddy retired, his pension from the UK and Canada was more than his pension that was being paid to him by the government of Ghana. Fortunately, he had his consultancies and all that, so, well, he wasn't. So, as I said from the start of this conversation, and that's why I used my dad as an example, because I heard the last speaker talk about why doctors or health professionals, why shouldn't it be engineers and all that? And what I'm trying to say is that patriotism never fed anybody. And I'll point this out to you. In 2014, my mom passed away in 2015. This was a woman who was coming in and out of the UK and Canada because that was where she had lived. And in 2014, 2013, sorry, she was diagnosed with endometrial cancer towards December. So we're all in Ghana, grandchildren, children, everything for Christmas. And the idea was to fly him abroad and seek care. But the consultants told us that because he was having issues with blood clotting and all that, and his INR and D-dimer was all over the place, she might not survive a long trip. So we had to stabilize her in Ghana. Fortunately, because my dad was a professor in tech and all that, and a lot of the current professors and a lot of them also were children of professors in Care University campus, she got excellent care. I would never fault anyone for that. But that made me see the reality of the situation, because the medicines that she was being prescribed, the Clexanes of this world and all that, were not on the NHIs, and they were, there are doctors on this program, they can tell you to keep her from 2013 till August 2016 when she passed that, and at times being on an injection of 40 international units of Clexane every single day. They know how much it must have cost us. And I asked myself, so when he passed, I asked Dad, we were sitting in his study when we were coming for the 1 week, and Dad was like, these are the things that make me regret coming to Ghana based on patriotism. Because you know what? If you guys were not out there, how were we going to afford keeping your mama? And why am I sharing this? I'm sharing this because I've shared it in a public lecture at the British Council Hall last year. So it's public knowledge. And the last year, my dad passed away. And the same thing, geriatric care is non-existent in Ghana. So even though, yes, he had lived a fruitful life, he was almost 90 and all that, the end of life care that he had to receive, again, we're just fortunate that we had friends who are experienced medics and who could give us nurses to come and look after him at home. But it made me wonder, what care is the general John on the street getting when they get to that stage of life? So if I put all those things together, and that's why I talk about the push and pull factors. You cannot convince me about patriotism, because at the end of the day, if I were to be fortunate to live to close to 90 as my dad did, if I am going to find myself in the situation that my dad found himself, that scares me. Because if my children are not fortunate to have the network, hopefully they would, to keep me comfortable, because at that stage, I am not going to get better. All I need is to be kept comfortable in my final journey out. It frightens me. And if you've heard, my colleagues say that the Ghana Health Service was trying to tell them to take money out of their own salaries to insure themselves to prevent them getting into these situations. You cannot convince me that patriotism should allow them to do this. And that is why, before I was cut off, I was going back to official reports about what our health system needs and about why journalists, citizens, you see, I get so surprised that we are in an election year and health is not an election topic. And some of these, what do you call it, official documents like the Health Harmonization Assessment Report, which gives a dire verdict on our health facility, is not being discussed. And we are not saying that these are the number of doctors we have. You build Agenda 111, you do not have the health human resource, because health employment is a pyramid. You need a consultant at the top, and then you have specialists, and then you have senior registrars, and this, it gives you can do the calculation to give you the number of principal nursing officers, nurses, blah, blah, pharmacists. That is how health employment works. We all know it. So if we know that, and we know that there's a limitation, and that we cannot even get financial clearance for nurses who are sitting at home who are losing their vocational skills, then I ask myself, how would patriotism make me stay? It wouldn't make me stay. And that is why, before I was cut off, I was saying that we need to have a proper conversation. We need to get all the documents out from the Statistical Service, from the Ghana Health Service, from the Ministry of Health, from the WHO, that actually does a post-mortem on our health system. That tells us that our life expectancy has hit a plateau and in the last 2 years has dropped by about 0.5 years. And ask ourselves, what are we going to do about it? If we don't do that, then we are having these conversations in knee-jerk reactions and it's never going to work.
Kwame Asiedu-Sarpong is a CDD Fellow on Health. Studio, Professor George Boateng Kyei, a consultant physician, Noguchi Memorial Institute for Medical Research, is here, as well as Dr. David Tenkrantwum. He's a lecturer at the University of Ghana and also the General Secretary of the Ghana Registered Nurses and Midwives Association. Let's look at government and policy. What should we see happening next year, going forward? What kind of policies, what kind of policy direction should we begin to put in place to curb this brain drain? Because it looks like, although it's a 20-year cycle, this year's cycle is like a lot more, it's a lot more massive. If someone is picking her colleagues at the airport regularly, then we are in trouble. What should we be looking at from GRNMA's point of view, first of all?
All right, thank you. I think that it's not far-fetched. We've seen this phenomenon before. What did we do right? Okay, so for instance, if we immediately decide that we will peg the market premium of health workers, doctors, nurses, midwives, pharmacists, anesthetists, to the current basic salary, it will stem the thing. I'm telling you.
Just like that.
That's number one. Number two, we had something called car waiver. Okay, I don't know how it will sound. Maybe perhaps there could be policy dissonance or that, but we think that that car waiver enabled doctors and health workers, nurses and midwives to import cars into Ghana without paying duties. All right, of course, some few duties were paid, national health insurance, the rest of it, but largely the duties were waived, and it was cancelled. Okay, it was cancelled in is it 2012 or something like that, and we think that it should be brought back.
We're assembling cars in Ghana.
Of course, that's what I'm talking about, policy disorder. But how much can a nurse or a doctor buy any of these cars that have been assembled in Ghana? Unless they decide to maybe give it to us and then we pay. But what is your purchasing power? That is where the problem is. So the purchasing power is not even there. So if government says, okay, we are assembling cars in Ghana, so let's give you whatever. You see, the cars that we're bringing, not like luxury cars, not SUVs. I mean, the engine capacity shouldn't exceed 2.0 cc. So it wasn't like we're bringing sophisticated cars. It was 1.8 liter engine that was allowed. And for 5 years.
When did this incentive start and when did it end?
I think it started in 2004, I remember. President Kufuor brought the car waiver. And then it was removed in 2012. And the current administration, promised it, is in their manifesto. They never brought it. And we've been at it. Recently, I got a hint that the recent budget that was read, not the midterm budget, the last year November budget, I mean, they mentioned that they're going to restore it for Ghana Medical Association. But I remember my president and I meeting the vice president at the Jubilee House in 2020. And we placed this before him, that it ought to be done for nurses and midwives and other healthcare workers. It cannot be done for one group of persons and leave there. It won't work. Because those who are living in droves are actually the nurses and midwives. Okay? And like what Dr. Z, I always say something, if you meet a bad doctor and a good nurse, you are in good business. But if you meet a good doctor and a bad nurse, you are in trouble. The reason is, if for any reason a physician writes something and I'm a good nurse, I'll be able to see it. Maybe the person has overworked himself and medical errors are there.
So you call attention?
So I call attention of the physician. Oh, look, I think, and I have done that several times in my practice, even in theater, when we are supposed to maybe do certain things. So when you have a good nurse, because the nurse gets to stay with the patient for 24 hours. So any medical error is detrimental. Because he's the last point of administering. Doctor comes, he writes, he goes to pharmacy, pick the medication, or the pharmacy brings the medication. You understand the point? So I'm the last point of offering certain services to the patient. If the doctor wrote A, B, C, D, I'm the one going to introduce it to the body of the patient. So if
you have a good doctor and a bad nurse,
you are in trouble. Because
even though the doc wrote the right thing,
you can't even give wrong medication or at the wrong time and stuff like that. So you see, it's absolutely important that we comprehensively deal with the challenges in the health sector head on and stop this what do you even call it, divide and rule, and because ad hoc and rhetorical approach of doing things, it's wrong. How can you restore? Yes, I thank God they are going to restore it for doctors. It's good because they are living. But what about the rest of the health workers? And especially those of us who have very low purchasing power. So that 1.8 liter engine is not anything. I'm not saying that we should allow us to bring SUVs and Mercedes big cars and stuff like that. 2.8. No. Something small. Look, when COVID came, health workers were rejected virtually, were stigmatized. If you wore a uniform and you sat in a car, not when the lockdown was there, but when the lockdown was lifted, people begin to, even I knew a nurse who was ejected by the landlord. That,
oh, wow.
I'm telling you see, terrible things come before us as union leaders. We have to step in.
Just that something that she or he has gone to work with some COVID patients.
She was working at GAEC. What's the name of that place? The new hospital at Atomic. Yeah, that's where we declared as COVID center. That was one of the COVID centers. Yes, these are practical issues. And many other healthcare workers, because nurses tend to wear uniform, they are easily identified. And if you are going to sit in trotro, you see people shaking as if, can you imagine, you are not a Ghanaian. So if we had such a facility, why cancel it? Why can't it be brought back? So that if you have a small car in your apartment, you see, sometimes we want nurses to stand by the roadside so that we can offer them lift and stuff like that. Why can't nurses also offer lift to other people? People will say that, for doctor, you see, it's true. I mean, it's a very, God-given vocation and all that. But my brother, we have children to take care of. We have families to take care of. Look at me, look at Prof. So, I mean, it's a terrible thing, and I think that we need to find a comprehensive way. So, I've talked about the reintroduction of the car waiver. I've talked about the improvement in the market premium, and I've said, because I know what I'm talking about. If you compute, let's say 75% of my basic salary right now, add it up, it will appreciate it considerably, and it will help. Okay, I would have wished it even get consolidated so that it can reflect on my pension. There's one thing giving allowances, and there's one thing because your pension deduction is based on your basic salary.
It's true.
So no matter how allowance you receive, if the basic salary is low, you go home crying. And we have to even look at those conversations. Okay, I sit on the health sector pension, occupational pension scheme. Health sector occupational pension scheme as a trustee. And if I tell you the amount of money doctors, nurses are going home with on the tier 2 pension, you'll be amazed. Terrible. You see, it could have been worse on SNIT. But I'm telling you that now, it's nothing to write home about. You've worked for 39 years as a pediatrician, 35 years as a neurosurgeon, and you go home with peanuts. So it's a terrible conversation. One, we have to look at the basic salary, and number two, other allowances. Do you know that graduate nurses in Ghana do not have any allowances? When I say graduate nurses, nursing officers and above, nursing officers and below, none of them have any component of an allowance on their pays apart from that paltry salary that they receive. No allowance. Can you imagine? That somebody has finished University of Ghana, is a graduate nurse, and doesn't have any component of allowance. No food allowance, no rent allowance, no housing, nothing. They tell you that those allowances are perquisite and it's meant for category 4. Category 4 means directors and above. And somebody is a graduate nurse. And you see, you can't pay the entire rent. So, for instance, if I'm renting at 10,000 Ghana cedis a month, if you even give me 500 Ghana cedis to sort of as a subsidy, it makes sense. It means that you think about me. You see, these are some of the things they think that they don't have a future. They think that the government doesn't think about them. The public don't even think about them. They always talk about patriotism and stuff like that. Meanwhile, patriotism does. Look, we didn't sign an oath of poverty. And I want to make this clear to everybody in this country, that nurses and doctors and all other healthcare professionals, they did not sign an oath of poverty. The hypocritical oath, poverty is not part of it. Similarly, nurses, we pledge. We have nurses pledge. We never pledge onto poverty. The fact that we pledge to take care of Ghanaians doesn't mean that we have to be poor. Because, you see, if I'm not psychologically, socially, and spiritually sound, I cannot offer that best of services that you require. And you go home crying. You see, it's a terrible thing. Sometimes I don't want to say certain things, but I've been in the clinical area for a very long time. I've seen quite a lot. And I think that we need to take care of health workers in Ghana. Let's prioritize them. Yeah. Previously, we were migrated. You know, we used to be on Ghana Universal Salary Structure GOOS. Then they migrated healthcare workers onto HSS, Health Sector Salary Structure, HSS. Before we were placed on the single spine. So health workers had a different salary structure, and it was helping. When we consolidated the ADHA, we couldn't sit on the GOOS. So we had HSS 1, of course, for doctors, HSS 2 for the rest of the health workers. And that was better. Okay, if you have sent us on the single spine, and that allowance that we're receiving on the HSSs has been, if you like, consolidated and designated as market premium, why freeze the market premium and make us worse? So we should lift that thing immediately and peg the current basic salary or the current market premium to the existing basic salary, and that will show up our income. And things will be better.
Thank you so much. That was the very passionate Dr. David Tim Kranchum. He's the General Secretary of the Ghana Registered Nurses and Midwives Association, so you know where he's coming from. Very passionately delivered. Prof, you've been here and there. Are there any policy interventions that you think will be able to curb this brain drain that we're not looking at?
Oh yeah, I mean, there's a lot. And this is not rocket science, and this is not something that our policymakers don't know. I mean, so for me, that is, I'm not going to say anything new that nobody knows, because these are things like, you know, the City Upon said, reports have been written and shelved and written and shelved, you know. So yeah, for good measure, I'll add more to what Dr. Tingran has said. You know, first is that prioritize hiring of the nurses and doctors who are finished. Nurses should not stay home for 3-4 years after they finish.
And fry both fruits, you know, in
exactly.
markets.
I mean, that for me, that is like number one. I mean, prioritize that. As soon as they finish, get them into the system. Because when you get them into the system and they start working, some of them will stay.
Good point.
Yeah, some of them will stay. You know, but if they finish and they are there, you know, frying both fruit, of course, they will think twice about staying, okay? So that is number one. Now, the second one is that, like I said, the distribution of the doctors, of the ones who are here and the nurses around the country is not good enough in terms of, especially the rural areas. We are all in Ghana, but Ghana is not the same everywhere. I've heard some policymakers saying that, oh, you know, Ghana is one Ghana. It's not one Ghana. If somebody is in a village somewhere, you need to give that person some incentive. This is even done in the US, where like doctors who serve in the rural areas get paid more. Sure. And the rural area,
countryside,
you know, it's like very nice, okay? And you have all of the facilities that you need. Sure. I mean, I've gone to like so-called rural hospitals in the US, and I'm like, oh, okay. Okay, so, and the doctors there get incentives to go there. So I don't see why, if we are sending a young doctor to a district hospital, the minimum we can do is to give them a very nice and beautiful accommodation and maybe multiply their salary by 2. If you do that, some will go. Sure. I'm not saying it will stop everything, but some will go. And when they go, they will stay, they would start a family, and they will stay in the country. Okay, and this is not hard. I mean, come on, are you saying we cannot build, you know, how many doctors do we even have in this country? Okay, I mean, 3,000-4,000 people, and the few that we are going to send to the hospitals, the district hospitals, we can't get nice bungalows for them. You know, I mean, how much does one Land Cruiser cost? Okay, so we have to prioritize these things. The next is to increase or improve the working conditions. You see, as professionals, when you've learned how to do something and you go to the clinic and you have to improvise and the things are not there, I mean, it's not good. The next one is to immediately provide full medical coverage for doctors, nurses, and other health professionals and their families. Full. And I mean full. 100%. Because I don't see why a doctor is working at Kolebu. Okay. And then when he is sick and needs surgery, needs to pay from his own pocket. I mean that is just ridiculous. No, I mean, truth be told, that is just ridiculous. I mean, if you are a young doctor and you see that, what is going to make you stay in the country? Okay, so those are easy things in my opinion, okay, that we can do. And of course, we need to also keep improving the training. But you see, if you keep improving the training and you don't do these other things, they will get trained and they will leave.
It's true.
Like the nurses, you know, all the specialist nurses have left. A lot of them have left. Okay? Because they train as good, let's say, anesthesia nurse or, you know, critical care nurse. They are very wanted everywhere in the world. So, somebody, if you won't take care of what you have, somebody will take it.
And they do it deliberately. Is the West deliberately lowering the bar to rope our people?
They are not lowering the bar. They are not lowering the bar.
Because you said this time you write some exams.
Yes, but the training here is good. That is why they like us. It's good enough? Yes, it's as good, you know, as anywhere else. So they will take them. And will you blame Canada, US, and UK for taking our people? I mean, we can do all the blame game, but at the end of the day, we have to take responsibility for our own lives. I mean, if you have trained people and you say you don't have money to hire them, won't somebody take them?
Definitely.
Yeah, somebody will take them. I mean, why will you spend the money to train somebody and say that I don't have money to hire them? Of course, somebody is going to take them. So, I mean, I don't blame them. You are in one little world, right? And, you know, economies of scale. It's a global market. It's a global market. So we need to be competitive. And why we're being competitive is solving some of these. At the end of the day, it's our country. People really want to stay. It's not easy staying abroad. I mean, you are a foreigner. You know, in some of this place, there's racism, there's this and that. You know, so people ideally will want to stay in Ghana. Even when you leave, your parents are here, and today they are sick, and you are stressed. You know, it's not fun. And the other thing that Doc was talking about his, you know, parents. That is one thing that really, really bugs me in this country, that in our healthcare system, if you don't know somebody, the care that you receive may not be optimal. That should not happen. It should be that anybody on the street who gets sick and gets to any care facility receives state-of-the-art care. But because we don't have the facilities, we don't have the people, you know, that's become like, you know, so like, let's say at UGMC, you know, we are trying to kind of end that kind of thing. That, okay, just walk in, so people will call me, oh, I'm sending I'm like, just go to the emergency room, they will take care of you.
Nah, I have to make a call.
You see?
Look, call somebody.
You see, you see that kind of thing should end. Okay, because health should not, we should not discriminate. You know, anybody who enters the facility should be taken care of, you know, like anybody else. Okay, because if we don't do that, it affects all of us. I mean, okay, now I'm Professor UGMC, they know me, so if I go, fine. What if I get an accident on some other road and they take me to somewhere that nobody knows me? Yeah, that nobody knows me. You got what I mean? So that kind of thing should end. And it will end when the healthcare workers feel like they are being taken care of. They feel like, you know, they matter, you know, and we should, you know, there's a lot of criticism of, you know, nurses and doctors and, you know, they are not nice and all of that. But look, let's take care of them first and see what happens.
That's a good point. Let's take care of them first, and then we see what happens. Still on policy, Dr. Kwame Sirisapon, if you're on the line, is there a policy initiative that could stem this brain drain, which we haven't touched on in this discussion?
Well, like I said, and Prof has just reiterated the point. Like, if this program ends, go and look on the Kampala Declaration on Health Migration. It clearly states what we have to do, and it clearly states what the West and developed countries must do. The West and the developing countries have actually done what they have to do. Ironically, even though they are still poaching. So, for example, Ghana is still on the red list of countries where you cannot actively recruit from. But here's the catch. In that same document, it also says that you cannot prevent someone, an individual, from traveling because freedom of movement is a fundamental human right. So the West wouldn't come to say Ghana and say, I've come with an agency to actively recruit. But like Dr. Tenkra was saying, if a nurse has gone to the United States and is working, they say, do you have any friends who want to come? It says, I have X, Y, Z. That's not active recruitment. That's referral. It's allowed. But we have to then put policies in place to make that nurse comfortable in Ghana so when the referral is made, they wouldn't move. I can give you a tip and another example which is happening in the UK now, and I'm quite sure Prof and Doc would know about it. A lot of the nursing homes, because now there's been a new law which says that when carers are coming to the UK, they cannot come with their spouses and children. A lot of the agencies or hospitals and especially nursing homes in the UK are using a different strategy. The strategy is we have a backlog of nurses. So why don't you then get these people to come in as carers? Because a lot of them have just graduated with a degree, they do not have children, and they do not have spouses. When they come in, they can write the IELTS here, they can then write all the necessary tests, and then they become nurses for them. So while we are not putting policies in place to address getting financial clearance for these nurses, another country, not planning globally, but people in there who need the expertise, because like Prof said, the training is as good as anywhere else. And they have seen over the years, Ghanaian nurses and doctors come, pharmacists, and excel in their health systems. So they have no problem getting more in. They are saying, okay, the people are sitting at home, rather I'll get them in as a carer. And when I get them in as a carer, they can come and write the necessary exams. And within a year, 2 years, they are nurses. Then they can bring their spouses in. So you see how the same document, the Kampala Declaration, is being adhered to by one party, but they are finding loopholes to still recruit. And we are just paying lip service. A lot of people have even forgotten that document exists, and we're doing nothing about it. So it is not about any new policy. I would always say that we know what we have to do. Our shelves in our policymakers' offices are littered with official documents, declarations we've signed, acts we've signed, WHO General Assembly, statements that we've adhered to. Now the latest buzzword that we are doing is UHC, Universal Health Coverage by 2030. One of the things that is in that document is that finance should not be a barrier at the point of use of healthcare. And so should all these discriminations that Prof was talking about, where you have to place a phone call before you get service. Our politicians are doing very little about us getting there, because this is not down to the technocrats. It's down to the politicians working tenaciously towards it. They are doing nothing about it. So what makes you think that if we brought in any new policy or put out any new policy document, then suddenly the approach of policymakers would change? It wouldn't. What we need to do, and that is what I've been trying to draw everyone's attention, is to get the public, led by the Fourth Estate, to start discussing some of these documents, bringing health professionals on board, bringing policymakers on board, and asking the questions: why have we signed on to these things? We signed on to one in 2020, we didn't. We signed on to another one in 2014. All health professionals who work in the policy space know. We need to start asking the question: why do we just go for these tea drinking events, sign these things, eat the caviar, drink the wine, and come and do nothing with the policy document? That, for me, is where we need to start from. It's about ensuring that the ones we have signed are being implemented, and the documents that are telling us what the problems are being utilized. The statistics from the Ghana Statistical Service, etc., the statistics from Ghana Registered Nurses. You see, and that's the other thing that our policymakers are very delirious of. The Ghana Medical Association has a lot of statistics. The Ghana Registered Nurses have a lot of. The Pharmaceutical Society, they would never go to them and say, "What is your statistics telling you?" So what makes you think that?
On the issue of this being up to the politicians and also to the Fourth Estate, and I know this one is coming straight at us in the media. Let me find out. We now have a medical practitioner as the health minister. Should that not change the narrative? Or is it a good argument to have a health practitioner lead the sector?
Well, let me put it this way. It is not about the leadership of the sector. Policy is a different animal. Policy works by the executive, right from the top, cabinet, committing. Like, did you saw what happened with what do you call it, free SHS? At that time, the minister was a health person, but it didn't matter. No, there was a commitment to land that policy. That is the sort of thing health needs. Because you know what? Let me end it this way. Maybe that would draw your attention to. Ghana has become a conveyor belt of training. Our life expectancy now is 63.9 years. Our retirement age is 60 years. If you look at our statistics, 60% of all Ghanaians who retire at 60 are dead by their 65th birthday. And therefore, our population above 65 years has remained at 3.05% for the last 35 years. What does that mean? We do not have any elder statesmen who are transferring their generational knowledge to the young. So we are always swimming against the trend. If this doesn't scare us to do something about our health system and realize that we need professor emeritus in our medical schools and other things, our pharmacy schools, our nursing schools, to train more people, to give these people the confidence that you can grow in this system and become self-actualized, then we are joking. That is the basic point I'm making. And that is down to policymakers having a zoned-in approach to prioritize healthcare. And that would only happen if the population at large puts them under pressure. That's how I'd want to end.
Much, Dr. Kwame Siedu-Sarpong, CDD Fellow on Health. I want to come to the studio and wrap up. We have just 4 minutes. I've been prompted. Okay, so Prof, if like Dr. Siedu-Sarpong said, we all agree that policymakers know the problems and the solutions, but nothing changes. It's down to bad leadership, failed leadership. What is it? Because he said he's not bringing a new policy. We already have done it. What is it?
No, I think it's not about bad leadership, it's about prioritization. And, you know, politicians and policymakers have a lot of things on their hands, right? So you need to get your voice in there. And I think health affects everyone. So I strongly agree with Dr. Siedu-Sarpong that the media and the general public should help the health professional associations to put pressure on whoever is in government to implement these policies. Because these policies, like I said, it's not rocket science. They are well known, they've been well documented, we know what is going to work. So it's not like we are inventing anything new, but it's all about doing it, right? So in Ghana, we like theory too much, instead of just doing, So I think it's the doing that is lacking. And that won't happen if you and I don't put pressure on whoever is in government to do what they've signed up to do for the population.
Okay, so that was Professor George Boateng Kyei, consultant physician, Noguchi Memorial Institute for Medical Research. We want to give the last word to Dr. David Tenkrantwum. He's a lecturer at University of Ghana and also the General Secretary of the Ghana Registered Nurses and Midwives Association. He has the last word. Way forward.
Way forward is not different from what Prof has alluded to. I think that the politician must take the bold decision and prioritize the health sector and give us competitive remuneration. Okay, and that's why I like what you said. I mean, how can we go to hospital and pay from our pockets? We are taking care of people. I mean, it's difficult to appreciate some of these things. And when we say it, sometimes people doubt it. Okay, when we put it across, people doubt it. There was a day, I think I appeared on one of your sister stations. Are you sure of what you are saying? I said, how can I come and say that?
Yeah, I'm also wondering.
Exactly, and that is true. And I thank God Prof is here to complement whatever or corroborate whatever I'm saying. That's the case. So they should give us free health care if we are dependent. Of course, not if I have 10 children. I'm not saying 10 children. I mean, 4 children and your spouse, it makes sense. That's what we have in our collective bargaining agreement. And that will suffice. And as I mentioned earlier on, the improvement in the salaries, okay? And the hanging fruit, what can be touched on right now is the market premium, which was deliberately frozen. So just lift it, peg the current market premium to my basic salary, and I'm good to go. Plus the car waiver and the allowances that we are asking of. Why can't a degree nurse or a pharmacist, take fuel? You want the person to reach a principal grade. Do you know what it is for? You see, if you complete first degree, before you can reach the principal grade, you should have worked for almost 5 years. No, almost 8 years.
Yes, more than
Nursing officer, 3 years. Yeah, so 8 years before you can reach the principal grade. Why do we do that to ourselves? So if I complete university now and I'm giving maybe even 20 gallons of fuel, or maybe 500 Ghana cedis or 1,000 Ghana cedis as rent allowance, it can't take care of all, but at least it shows that the government thinks about you or the employer thinks about you. So that is what the government should do. And it's not record time, like Dr. said, it's not far-fetched. It is something that can be done. It's the political will. They don't seem to think that we are important. That's why people are leaving. And they continue to leave. I teach my students, I tell them that, look, I want you to stay. But if your parents are expecting you to also bring something home. Don't forget that the culture we find ourselves, we raise our children for them to come and also take care of us. That is the thinking of a typical Ghanaian. And you finish university and you can't even take care of yourself, let alone to send something home.
Okay, are we taking care of those who are taking care of us? Ask that question. Are we taking care of those who are taking care of us? Ghana's medical brain drain and blame games, a desperate shortage of health workers. That was a discussion today around the Z Roundtable. It's been passionately delivered by our 3 panel members. It's gone down perfectly for me. I don't know about you. We'll be putting the excerpts of this interview out there. Share, that is a list you can do. Share and let somebody get it. Then you are also helping we in the 4th estate to push this agenda there. Professor George Boateng Kyei, consultant physician, Noguchi Memorial Institute for Medical Research was here. Dr. Kwame Sirisapon, CDD fellow on health, joined us via Zoom. Dr. David Tenkrantwum, you heard from him. He's a lecturer at the University of Ghana and also the General Secretary of the Ghana Registered Nurses and Midwives Association. All too soon, Z in the morning is wrapping up for the week. That's our last show for this week. We'll be back on Monday. But thank you so much for joining us. I want to thank our panel members once again. And then what can we say? As always, before we wrap up, we say pray like it only depends on God. But please, work like it only depends on you. Have a good one. We're done. Till Monday.